I'm Dr. Adams, and this is one of 3 videos that I'm doing on ophthalmic cranial nerve palsies. Technically, I could probably do 4, but this is one of them. I'd like to talk about fourth nerve palsies, but first I'd like to talk about the cranial nerves. And so this is my model eye, and you can see that the model eye has 6 muscles on it. You have horizontal muscles right here that cause the eye to move back and forth. You have vertical muscles that cause the eye to move up and down. You have these 2 cyclovertical muscles, this happens to be a right eye, that have a torsional and depressing effect and a torsional and elevating effect on the eye. For all of those 4 muscles, there's only 3 nerves that control them all. There's a busy nerve that controls this one, this one, this one, and this one. There's a lonely nerve that controls this muscle and moves the eye out towards the ear. And there's a lonely nerve that controls this muscle up here and moves the eye down and around. So those nerves that control these muscles are numbered, not by order of importance, but the early anatomists basically, when they were accessing the brain, would take the top of the calvarium off and they would count everything that was sticking out of the brain. At that time, they didn't actually know what any of those things did. People figured out what all of the things that stuck out of the brain did later. But it turns out that there are 12 pairs, or a total of 24 nerves, that connect directly to the brain. And half of them actually have to do with ophthalmology. The first nerve is the olfactory nerve. It has nothing to do with ophthalmology, and I only rarely check it. Occasionally I'll take an alcohol pack and check the function of the first cranial nerve, but rarely do I check it. Second cranial nerve is the optic nerve back here that actually is the cable that connects the brain and the eye. Of course, that is how we see. It's the most important cranial nerve from an ophthalmology standpoint by far. The third cranial nerve is this oculomotor nerve that's busy, that controls this muscle, this muscle, this muscle, and this muscle. It also controls the diameter of the pupil and the lid height by keeping the lids open. The fourth nerve that pokes out of the brain controls this muscle up here, this one, that comes across the eye. And this muscle actually is very interesting because it originates along with these other 4 muscles all the way back here at an area called the annulus of Ziln that surrounds the optic nerve. So the way it gets from there to its, we call it an oblique position on the eye, this is my Kleenex muscle, is that it travels up to the orbital wall and goes through a little pulley called a trochlea, and then it takes a acute turn so that it can get to the eye. So when this muscle contracts, because that's all muscles can do, is they can shorten themselves, it is not pulling from back here, it's actually pulling from this, my finger is now the trochlea, it's now pulling from the trochlea and it pulls the eye down and around like that. The fifth nerve is a sensory nerve that innervates the cornea and some of the skin around the eye. The sixth nerve is the nerve that controls this muscle out here that pulls the eye out towards the ear. And the seventh nerve actually closes the eyelids. So the fourth nerve is the one that controls this superior oblique muscle. And this is one of the most confusing muscles for residents and training physicians and whatnot to understand, because it's pulling the eye down and around, okay? And its antagonist muscle, the muscle that does the opposite work, is the one down here that pulls the eye up and around. And so if there's a problem with the nerve that controls this muscle, and that can happen for a number of reasons. Congenital is very common in my practice. I'm a pediatric ophthalmologist, so I see kids. I actually had an 18-year-old yesterday who had never been diagnosed, but he had a very large palsy of this muscle, and he had a significant head tilt, and when we turned his head the other way, the eye went way up. And when he looked in towards the nose, the eye swung up like this. The reason that happens is because this muscle down here that pulls the eye up and around is basically normal. And since the muscle up here isn't innervated properly by the nerve, it's weak, and so this muscle is overacting. We call it overaction of the inferior oblique, is the inferior oblique muscle. So the things that can cause this, again, congenital can occur. Another common cause of palsies of this nerve would be what we call a microvascular infarct or a mini stroke. And that occurs commonly in people with diabetes, high blood pressure, and other cardiovascular risk factors, clotting disorders, that sort of thing. Of course, anything that's occurring along the entire tract from the brainstem where it originates to the eye, and it passes along some bony ridges, and it passes through something called the carotid cavernous sinus, which is a venous sinus right behind the eyes where the carotid artery comes in and takes a turn. If there's a problem in any of those areas, a problem in the carotid cavernous sinus, a tumor along the whole root of the nerve, or something like that, it can cause a nerve palsy as well. In general, when there's a mini stroke, it's a sudden onset, meaning that you have somebody who's, say, 60 years old, and they have diabetes and high blood pressure, and suddenly one day they notice that everything's double, and their eyes swing up, they have a head tilt, and it's really uncomfortable because double vision is very unpleasant. One of those people will present to my office with a story like that and risk factors, and generally what we will do is provide reassurance, and I'll oftentimes put some tape. I frequently use a small piece of tape that I have cut with a penny as a pattern around, so that it's a little over a centimeter, and you can place that right in the center of the patient's vision, and it will block the vision on one side or the other and suppress enough vision that they don't have as much double vision unless they're looking off to the side, and it preserves the side vision. Sometimes I'll use a press-on prism, called a Fresnel prism, but in general I like to watch those patients and see if they get better over time. If they don't get better, then I will order an MRI and labs and other things like that. Somebody like the child yesterday he's almost 18, who showed up in my office with a huge head tilt. He had enormous vertical fusional amplitudes, meaning that he was able to control his eyes over a much larger range than most people can. And just a very classic. Oh, he also had maxillary hypoplasia, where one side of his face was less developed than the other, because of a chronic head tilt. The side that is being tilted towards during infancy doesn't develop as much, and so we call it maxillary hypoplasia. So we had all these signs of a very long-standing fourth nerve palsy since birth. So he doesn't require an MRI or labs or anything like that, because clinically he has a congenital case. I do have adults who present with congenital cases, and again, they generally will have some of those signs, like large vertical fusional amplitudes, or maxillary hypoplasia, or other things going on that indicate this has been a very long-standing process that they have been controlling for decades, and they finally get to a point where they can't anymore because it's just too much work, and then their eye decompensates and it swings up, and they develop double vision. So the treatment for this is actually to treat this muscle down here. And there's various things that can be done. This is called the inferior oblique muscle, and this muscle actually starts on the orbital wall over here and then crosses across the eye and attaches in order to pull it up and around. That muscle can be detached and reattached to the eye. That's called a recession. That muscle can be cut in two, or what I oftentimes will do is take a large piece of the muscle out and throw it away and allow it to just kind of flop back in, and it will find a point of equilibrium generally to reattach. If that doesn't work, then sometimes I'll go in nasally and we'll approach the muscle again and remove as much of it as I possibly can. We call it denervation and extirpation, leaving very little of it behind to reattach and pull on the eye. So those are basic surgical treatments. Of course, we can treat this with Prism sometimes as well. And but it is oftentimes an extremely successful surgery with which patients are very happy. So I hope that provides some information about fourth nerve palsies and a little bit of information about cranial nerves in general and how they control the eye. Have a wonderful day.